We all know that we leave some residual FFD in rheumatoid cases. It is correctable with the time. What I have observed is that in 1 or 2 patients, they started developing peroneal nerve palsy on 3rd or 4th day. And now you are stuck, whether you want to continue stretching or you want to hold the stretch.
I think you have to hold because in these patients, you have to hold it because in these patients, you can give the time because this is stretching of the soft tissues. It can go up to the 2 years, 1.5, 2 years. So don't be aggressive in these cases if you have this palsy.
Because if we hold it, then also we have to wait for like 4 to 6 weeks for the palsy to recover.
Yeah, that is no should be.
We are losing time on the stretching.
You should hold it because FFD in rheumatoid patients is going to improve anyway with the time. So you should hold
You have to hold as soon as you get the palsy. I think you have to hold at that. Let the palsy recover, then go ahead with this.
See, normally the peroneal nerve palsy, if it has to happen, will happen immediate post-op. It won't happen in 3 days, 4 days time, and it will happen because if your valgus you are correcting too much, then probably it will happen immediately. It is not going to happen in 4 days, after 4 days or 5 days. Anil sir, any comment? It has to happen, it will happen immediately. It won't happen in 4 days, after 4 days, 5 days. And the rheumatoid, if you are leaving...
Sudeep, see, we have had cases, what happens is, in these flexion valgus, if you correct the flexion valgus, and if post-operatively you start applying brace, right?
Yeah.
If you are applying a brace or anything, then it happens, and it has happened with me also, and I've seen other cases also after 2 or 3 days. So the one thing is that in flexion valgus, you correct it to the point it can be corrected. It stretches somewhat. I would not say 100% it stretches, but it stretches a lot. And if any bracing has to be done, it has to be done after 4, 6, 7 days or so. Not immediately in the immediate post-op period.
You're right, sir.
For us, it's a pure no for any type of bracing in the immediate post-op, whether it's a varus or a valgus knee. Sometimes the patient develops blisters, the skin are not good, the soft tissue has not healed. So those are the cases in which common peroneal nerve palsy develops later on.
Yeah, this happens in one of my case that after 4 days it developed because of the brace. The pressure of the brace, they make it tighten on the knee and that patient developed peroneal nerve palsy.
So I think 2 things I want to point out. Don't have a lax attitude to peroneal nerve palsy. It will recover. I'm sorry. That's not a good attitude. It may not recover. Yeah. And it's a big disaster. So you should expect where you can get a peroneal nerve palsy before you even operate. What are the high risk cases? Flexion valgus deformity. If you have a flexion valgus deformity, you correct valgus as well as flexion in one go on the table, you may end up with a palsy. And that palsy will recover, I'm sorry, only God knows. So before you do that, I think on those patients, I've done 2 times, I do a primary release of the peroneal nerve before I start the case. I take a small incision laterally, just release the nerve around the neck of the fibula and be very sure that my nerve is relaxed now. I take that precaution. Now another thing, our attitude in general, I am seeing this for last 20 years, about leaving flexion deformity on the table. I think the surgeon thinks physiotherapist will do it on an old lady, they will press it for next 3 months, Mataji will be crying. I don't think it is fair. As surgeon, we should not leave flexion deformity on the table at all. I don't mind elevating the joint line by 2 or 6 millimeter. That doesn't make any difference. But to get the flexion deformity corrected post-operatively is again Ram Bharose. I don't do it. I get my knee straight. Whatever knee you give me, it has to be straight on the table. I don't want the physiotherapist to play with my patient next 6 months and make him cry to correct that flexion deformity.
But in case of rheumatoid,
I also wanted to make this point. There's a paper from Ganga now in which they have done for valgus knees from Ganga Hospital. They have done a prophylactic release of the peroneal nerve. Hemant, any comment regarding? You are here, so how can you? Yes.
I think prophylactic release is, I think, given up. I don't think anybody does it anymore. It was a described technique maybe 20 years back, but it's not done anymore. I have never done the prophylactic peroneal nerve release. Yeah, flexion valgus is a problem, especially if it is a post-HTS scenario, overcorrected valgus. These are nightmare cases to actually correct, and very high chances of peroneal nerve palsy. And they can develop post-op, so you have to go slow. I think on table you can maybe get up to 5 degrees of flexion deformity. Rheumatoids, you generally come in two types of rheumatoids. One is extremely stiff and rigid type rheumatoids. Those actually should be corrected well. But the lax type of rheumatoids, you can leave them slightly, flexion deformity. So you have to differentiate what type of rheumatoid it is and what the quality of soft tissues is.
I think the message is loud and clear that Dr. Maheshwari Bhatt said that is true for the osteoarthritis. The osteoarthritis, you have to correct even 2 to 3 degrees is not going to be corrected. But in the rheumatoid, it is shown example, it was the 2 knees sequentially, it's not valid, it one after one, and it has gone equally, there are many cases like that. So I don't think that it has to be corrected on the table. Osteoarthritis, definitely, you have to correct the table because it is not going to come back.
Okay. So we had very interesting cases of extra-articular deformities. So my question is that when we are dealing with very high valgus extra-articular deformities, and they have been there post-traumatic, maybe after fixation, long-standing, you do a lot of releases to get it corrected. So what is the experience with late onset laxity on the lateral side because of overcorrections? Probably intra-op also we land up with over laxity. And what should be the threshold of using a hinge? Because in our country, the cost is a big concern. But in West, we have seen that they don't bother too much about it, do all the releases, and just put a hinge. So what should be the threshold for using a hinge for these 30, 35, 40, 45 degrees of valgus, post-traumatic, where we are expecting the tissues, even after release, they are not so strong?
So I think MCL is a very sacrosanct ligament of knee arthroplasty. If you are not sure on the table that the MCL is in good condition, which is not in a severe valgus deformity, and you leave that patient even in 1 degree valgus, even neutral, that knee is going to fail. So my threshold for using a hinge is very low, and I've learned this over the year by trying to save money for the patient, blah, blah, blah. I think I've always repented. When you do a TKR, it is one-time operation, cost is not the issue.
Yeah, I would agree with that. I think MCL is the sacrosanct here, and many times it is stretched out. If you do a valgus stress X-ray before, you will see significant stretch out on the medial side. So although anatomically it might be a continuous structure, but still functionally it is very deficient. And balancing that stretched out medial side with significant amount of lateral releases to equal or equally balance it is tough, and those are the cases you really have to straight away go for hinge. And hinge is a very simple surgery once you choose to do it.
So the concern with hinge is not the cost, it is the survival. Yeah. So our focus is basically to do a knee that will last good 20-25 years rather than have half the survival of it. And it is good practice, like he has shown in that valgus case, it is good practice to convert those knees from a valgus into like 2 to 3 degrees of varus deformity.
No, that's fair, but if the medial MCL is significantly stretched out, you can't really balance with the lateral side. It's impossible to do that.
If it is thinned out, you can't, but your first attempt should not be...
No, obviously not. You're not jumping to a hinge straight away. You need to keep a constrained knee as well as hinge available to you on table, and on table you can take a call whether that MCL is, worth relying on or not. And important thing is this rheumatoid patients have a low demand patients. So survival is never an issue in rheumatoid patients. I can understand young osteoarthritic survival will be an issue, not in rheumatoids.
Low demand, but with osteoporotic bones,
yes.
So that will be a concern.
Post-traumatic young patients is a different scenario.
Even in rheumatoid, the bones are osteoporotic. So like we have seen hinges cutting out in mid shaft, and then you are. Yeah, we should
so there is no doubt that you should not use a fully constrained as far as possible. But don't worry about survival of a hinge joint. You have to make the patient walk next morning. Yeah. Or one. I don't bother whether it lasts for 10, 15 years or not. But my patient should walk after 1 month. So biggest reason for patient not walking after TKR in my experience is instability. They don't walk. If they are not stable, you have left him unstable with a partially constrained knee, hoping that this will last for 20 years, actually the patient never walked. So it's better to use a hinge, give a stable knee.
If you have an unstable situation, then you should use a hinge.
And deficient MCL or poor structural integrity of MCL, these patients are not happy and they will not continue to walk because MCL is deficient, it's the end of the knee.
I think the message is very clear.
Rather than having
we should not confuse people.
We can directly
use a
to
hinge.
the panelists and the speakers also.
Yeah.
where they are not
So,
given any chance
question to Amit
speak
Jaiswal.
freely.
So, Amit, you
So
showed
any, yeah.
yeah, you showed a very good case of extra-articular deformity. I think this you did before you bought the robot, because because we were all expecting and seeing that robot se hoga, is a plate bhi nahi nikalegi, screw bhi nahi nikale honge.
I think
So
this
if
case
it
was
is an
done before
indication-
robot.
Yeah. So, you know,
10 years back, yes.
before
Sir.
robot.
yeah, so I think, you know, for extra-articular deformed robot or any sort of technology, whether it's a navigation robot or artificial reality, or anything is much better. And I think you don't need to remove the plate and the screws, and then you don't need to bother about the stem at all. And even if you don't have a robot, now you have 3D printed, you know, jigs
Yes,
are
sir.
available for your distal cut. So that is one thing, you know, for any extra-articular deformity, you should definitely take help of, you know, technology.
Yeah.
I'll put my
One thing
question
I
to
would
Dr. Jaiswal on the same note. In your presentation, you said that the distal femoral angle was like 80 degrees.
Was like,
It was 80 degrees. You could not get your rod in because you didn't have the implant for 80 degrees. And you put your distal zig at 4 degrees of valgus. These two figures were there.
Yeah.
So, was there any calculation involved in the 4 degrees zig, or it is just a habit that we routinely cut it 5 degrees, it is a valgus knee, so we'll cut it little less? Second part of this question is, with the robot, if you're doing the same knee today, like would you alter your distal femoral cut and you'll pre-feed some figure into it, or you'll just do it according to the mechanical axis?
no, previously, before robotics, for any valgus knee, as we used to say that we have to cut the distal femur at a less valgus, because chances of post-operative valgus is more if you'll cut the distal femur at a 5 degree or 6 degree or 7 degree. So initially I started to cut the distal femur at the 3 degree, but at 3 degree my blade was not touching the lateral condyle. So I opted for 4 degree, where only slice of the distal femur I was able to cut. So with that 4 degree, because I don't have any navigation or any extra tool to for knowing the soft tissue balancing, so I opted for mechanical. I cut both, but on table I could realize that intra-articular part I was able to correct by soft tissue release, but extra-articular, since I had corrected only from 7 to 4, so my ligament was not properly balanced, so I opted for semi-constrained. Literature also says that even less than 20 degree coronal plane deformity can be corrected by intra-articular correction, provided you must have a backup of the semi-constrained and fully constrained. If you are opting for deformity correction for more than 20, either you go for extra-articular deformity at the same time, or a 2-stage, where you correct the extra-articular deformity and then you do the conventional surgery with a simple knee implant. Or if you are correcting more than 20, if you are attempting it, there are chances of damage to the MCL or LCL will be more intraoperatively. Then you definitely need to have a backup implant like a RHK or rotating hinge knee.
So in manual, you were just like giving it a hit and trial that, okay, 3 is not giving me any, but
Yeah.
how you do it with the robotics today?
Today, definitely we'll have a technology will see the medial and lateral opening before all cuts. So if I had to operate this case today, I'll see the preoperative alignment. Then I'll accept the tibial valgus around 2 to 3 degree. Will go for a functional. So around 2 to 3 degree, I will accept at a tibia, and around 3 to 4 degree at a femur. And we'll see the graph. If I'll be able to balance it with simple implant, I will go for simple. Even if I could find that even with cutting all these functional alignment sort of thing, I will not be able to balance it, then I'll definitely opt for a semi-constraint in this one also.
So I think, so thank you very much. I think all the panelists and the speakers, thank you all the persons on the podium for this wonderful session. Thank you very much.
Have a discussion on that, followed by the valgus knee. So Dr. Hemant is going to take both talks together, and Anil also has a talk. So I think, yeah, so may I call upon Dr. Gaurav Kumar, Dr. Gaurav, yeah, for his talk on robotic assisted TK in a varus deformity. Dr. Pradeep Kumar Gupta is not here, no? Dr. Pradeep?
They are all here.
नहीं, Dr. Pradeep Kumar Gupta मुझे बताया था नहीं है. No, he is not here. Okay.
एक announcement इनको रोक के करा दी.
Yeah, just 1 minute. Yeah.
डॉक्टर कर्मराज सिंह का मोबाइल है छूट
So I would be presenting some standard varus knees and would talk about how technology helps us in visualizing the deformity and plan the correction effectively. So this 69 years old male, a driver by profession, presented with a progressively increasing pain, both knees with the right side being more symptomatic. Planned a PFC-PH knee, used a standard medial parapatellar approach with patellar eversion. The soft tissue dissection was limited to excising the inferior fat pad and medial soft tissues up to the mid-coronal plane as much as required for a good exposure. So after removing the cruciates and the menisci, the medial osteophytes over the medial tibial and the femoral condyles tenting the medial soft tissues were excised. The initial leg alignment was then assessed by a series of movements across the knee in varus and valgus stresses. As was the case, the knee was tight and unbalanced medially throughout the range of motion, although it was pretty well balanced laterally. Laterally, the knee was balanced for an 8 mm insert. Medial tightness can be addressed by focusing on the femoral side. However, this plan was with a big femur of size 8. And since I was using the PFC system, this size 8 of attune is equivalent to size 6 of PFC, and size 6 femur PFC is not available. The biggest femur available with me was size 4. And downsizing the femur from 6 to 4 would open up the flexion space significantly. So the planned tibial resection was decreased and the slope was reduced. Post-tibial resection and with the collaterals stretched up, using the tensioning device, the flexion space was huge beyond the maximal insert size of 15, and also there was a significant flexion extension mismatch. So to balance the flexion extension mismatch, I could plan the femoral resection before actually executing the cuts. The planned distal femoral resection was increased from 9 to 12 mm. The femoral component was planned in 4 degrees of varus, and this balanced the extension space. On the flexion side, the femoral component was flexed, posteriorized, and externally rotated. This plan gave me a balanced knee with a 12.5 insert. And this was the alignment achieved with the trials. And this was the post-operative X-rays. The final insert used was 12.5. So the technology played a crucial role in planning the correction of varus deformity with what was available on the shelf by providing a clear visual representation of the expected outcome versus the desired outcome. This 68 years old retired teacher presented with a progressively increasing pain in the left knee. He has had a fibulectomy 3 years back with no significant relief. Clinically, he has a partially correctable varus with a lateral thrust. Radiologically, bone-and-bone disease of the medial compartment. So plan a standard attuned PH knee. So this was a lax knee with 7 degrees of varus, correctable to 2 degrees of valgus, and going into 7 degrees of hyperextension. As assessed, the knee was very lax, but more or less balanced. The tibial resection was decreased from 9 to 8. Post-tibial resection, the ligament tension was assessed using the tensioning device and went ahead with the almost the proposed plan that I might revise the distal femur if there is a flexion extension mismatch. After the distal and the anterior resections, I realized that there is a possibility of going further posterior. So revised the plan, thereby tightening the flexion space and correcting the flexion extension mismatch. This was the final leg alignment and balance throughout the range of motion that was attained. And this was the post-operative X-ray with restoration of the joint line and alignment. So this 58 years old male presented with the pain left knee and limb, clinically a partially correctable varus with lateral thrust. Full-length weight-bearing scanogram shows significant varus on the left side, and there seems to be some sort of a constitutional varus on the unaffected right side as well. The initial leg alignment was 10 degrees of varus and 3 degrees of hyperextension. The knee was tight medially throughout the range of motion. Since with the robotic device, it was very comfortable to revise the cut. An initial conservative tibial cut was planned. Post-tibial resection and tissues under appropriate tension with the device, the knee was well balanced in flexion. However, it was tighter medially in extension. So to have an aligned knee within the soft tissue envelope of 5-degree HK was planned. And the final HK achieved was 5 degrees with 2 degrees FFD. The graph showed a pretty well balanced knee throughout the range of motion. The post-operative long-length film shows restoration of the joint line and the constitutional varus as compared to the opposite side. So knee replacement surgery has evolved over time, and robotic assisted technology enables quantifiable measurements and precision adjustments of the femoral and tibial cuts, implant positioning or tissue releases so as to obtain optimal functional alignment. The precision offered by technology may make achieving non-neutral targets more reproducible. Thank you.
Yeah, I think we'll take the questions now itself because this is the only robotic talk. So otherwise, Dr. Maheshwari, sir.
So there's robotic session, I guess. There's a robotic session as well.
So next is also robotic. Yeah, maybe the next talk after the next talk. Yeah. Dr. Sandeep Vasnik.
Rajat. Hi, very good morning and thanks. It's been an honor here. So, my talk is about how to balance a varus knee and how technology helps us. So, this is the staging what we use for a classification 1, 2 and 3 according to Kim. Okay. What happens is whenever you do a surgery, it's at lots of arts also in which is it. The aim of a surgery for a varus knee is actually to make a medial sleeve exactly equal to the lateral sleeve so that both of the side, okay, they reach the same length. Okay. We do an anti-clockwise release, we do a from top to down release, which is more what is the principle of knee replacement surgeries. This is how we do it. Okay, for our conventional knees, we start at 6 o'clock, we gradually go to the capsule, osteophytes, deep MCL, superficial MCL, depending upon the need of the surgery. This is a very important picture. For the remaining part of the talk, we have divided into a zone 1, zone 2 and zone 3. Zone 1 only constitutes the osteophytes, the capsules. Zone 2 consists of deep MCL, posterior if you go, it is semimembranosus. Zone 3 consists of superficial MCL and gracialis and some parts membranes greater distal to the zone 3. Okay. What has changed? Okay, we are doing knee replacement such a long time. What has changed over the time? Okay. The perception of how we approach the knee when we do a robotic surgery, that is the difference what we have right now. What has happened is, what we have seen in all our consecutive patients is, we have almost stopped doing soft tissue releasing in stage 1 deformities. Only the osteophyte clearance in stage 1 and 2 in some patients. Osteophyte clearance with zone 1 release in stage 2 and 3. What we have seen is, in majority of our patient, none of the patient or majority of the patient, we were able to go ahead without any releases in zone 2 and zone 3. What our experience, the 412 consecutive robotic surgeries, these are all the inclusion criteria, what we had, the demography of the patient, which are more so for most of the part in India. According to the classification, what we did is 0 to 10 degree, we had 1 in 76 patient, 10 to 20, 212, and very severe 20 to 10, number were 24. The results were no soft tissue releases required to knee, which are the milder knee, osteophyte clearance in mild to moderate according to Klinger-Lawrence classification, osteophyte clearance in zone 1 and moderate to severe knees. Okay, only 6 cases which we need to go ahead and do a zone 2 and zone 3. Very, very severe deformities, rheumatoid patients, we had to do it. Okay, this is how we do it. If you see, this is case 1, stage 1 patient according to the Kim classification, what we do. If you see no releases, if you see the soft tissue, I do a subvascus for it. So if you see no releases at all on the medial side, the whole medial cuff is intact. This is what the initial registration on Vallis, the equivalence graph. Okay, it was the maximum was going to till 6 degree only, and this is what the soft tissue which was showing an equivalence graph. This is after with what the tibia resection what we do. This is the post tibia resection. There is a device what we use called a sensor tensor device, which gives you a real time balancing and understanding of the soft tissue across which is going in the knee joint. Okay. So even after this, if you have something, you can go back, correct the knee, and we can have something, the changes in the femoral resection so that you have a equal flexion and extension gap. If you see right now also, majority of the part, when we're going through the range of movement, majority of the balancing is already done. We don't have to do any releases at all. We just went ahead, we accepted it, we did not did any changes at all. My plan is always to give 1.5 lakhs on the flexion side for a better external rotations. And the medial side, we just keep it, sometimes we balance it, or 0.5 to 1, we keep it the way. Okay, and this was the final chart when we have what happened. Okay, and we had a good good outcome after this. Some issue, the video is not playing and neither it is going ahead. Can you see it from your side? The video and even this has stopped. Meantime, what has happened? Just come on. What we have seen is, in majority of the patient, what happens is, I feel that good soft tissue balancing with the adequate releases, that is optimum. We don't need to release most of the structure. If you see many of the deformities what we have, we never have to go more than the posterior medial aspect, never have to go. In very rare patients, are you able to connect? In very few patients will have to go ahead and do releases for those patients. Okay, so without any releases major, because actually we are going to have a real-time understanding of the soft tissues in these patients, so many of them will go away without any releases. Okay, this is the case 2. If I want to show stage 2, stage 3 according to Clegg-Lawrence, if you see no releases, just the removal of the osteophyte on the medial side and lateral side, no releases at all on the medial side. Okay, this is what the AccuBalance graph, the initial assessment, tight medial structure. This is what we had accepted for the tibia. I do a tibia first. It's a PS knee is what we are doing right now. Okay, this is the post tibia resection. If you see the amount of varus which is still going to tend to, I'm giving the hyper flexion and extension. I'm going through the maximum laxity which can be assessed with this patient to understand whether we are going to, what are the final outcome with this kind of patients. Okay, this is the femur resection planning. What we did is so if you see, there are more than one method to achieve the balancing what you have. There are different permutation combination. I think if I plan in some way, some other surgeon might be planning. It's a different philosophy what we accept. Majority of the patient, we are able to kind of take care of these patients with good alignment, okay, with the principles whatever. That is what robot helps. It's not like something, it helps us in the OR to understand the things better. This is the final balancing what we accepted before we went ahead with the final cuts. Okay, and this is the final thing what we got. So most of the majority of the patient we get a very good balancing. I always like to keep the latter. This is the picture post-op. In very severe deformities also, just 1 minute more. Okay, in very severe deformities also, in deformities like this, okay, still the same, we remove all the osteophyte, we'll take care of all, without releasing any structure, just remove the capsule, just remove the osteophyte which are there on the medial side so that none other things are released. This is the initial assessment. If you see, it is going to 18 to 19 degree of deformity in the varus. Slight hyperstretch of the obese lady, little bit higher hyperextension. This was the initial AccuBalance graft. This is after the releases, tibia resection. Only the osteophyte were removed. No, I never go to the posterior middle aspect at all in any of my patients now. Post tibia resection and the final x-rays for that particular patient. I used a small chubby stem for this patient because of the obesity what the patient has. The same way, a difficult case, going ahead, releasing on the medial side. This is the AccuBalance graph for that particular patient. 20 degree of varus, 1 degree of extension. This is after tibia resection. This is how we do it. No, only the osteophyte removal whatsoever is present in the tibia. We only remove that part now, no further release. I avoid keeping the medial spike more so that I don't dislocate it. I only dislocate it time it is because many times when you do it, you release on the medial structures also. Okay. This is the AccuBalance graph after that. So what is the thing? So the robotic assisted calculation of the laxity of the medial and the lateral structures, and which we get throughout the range of movement in a robotics, it helps us to better understand the basic anatomy. So we can titrate the releases whatever I need in this particular patient. There is an ability where we can modify the bony resection, achieve the balance gaps whatever you want without much soft tissue releases. We also have a detailed analysis. We can predict what is going to be the outcome after this particular surgery also, which helps us to do the surgery without committing to bony cuts. And I feel my suggestion and my assumption before we did the study was robotic assisted TKR requires lesser soft tissue releases as compared to a manual surgery. Thank you.
We'll have the questions on the robotic talk. If there is any question, you can come on the mic.